Good morning, good morning. Let's get started. So welcome to our first panel, which is an introduction to women's health and why it's been neglected, a manifesto for change. Now at Pause Live, we have created a manifesto for women's health, which I'm sure you can check out on our website, which is highlighting gaps in healthcare. Now, our panelists this morning, as you may realise, this is not Dr. Itunu Johnson-Shoberton. This is Professor Joyce Harper, who has stepped in at the last minute. Thank you, Joyce, for joining us. Now, Joyce is an internationally recognised educator, author, podcaster, and professor of reproductive science at UCL's Institute for Women's Health. She's dedicated her career to advancing women's health education from puberty to menopause. She's a co-founder and co-lead of Intune Menopause Education and Support Programme, and her work, including her acclaimed book, Your Fertile Years, and her global podcast, Why Didn't Anyone Tell Me This?, has helped countless women navigate their health journeys with confidence. Joyce, thank you for joining us on the panel. You've stepped in, helped us at the last minute. Now, my other amazing panelist next to me here, this is Tracey Dennison. Now, I should be able to introduce you without reading my cards, but I will forget some of your many achievements if I don't do that. So let me find the right card. So Tracey is the Nurse Director of East Riding Aesthetics and Wellness and a British Menopause Society registered advanced specialist. She was also named our Menopause Nurse of the Year. We run another event called Menopause in Practice for healthcare professionals, and Tracey was our Nurse of the Year at that. And next to her is our Doctor of the Year, Dr. Hazel Parkinson, a GP and aesthetic doctor, award-winning menopause specialist and advocate for joined-up women's healthcare. As I mentioned, she took home our award for Best Menopause Doctor, and she's a member of the British Menopause Society and the Primary Care Women's Health Forum. What an amazing panel we have for you this morning talking about women's health. So why do you think, I'm going to start with you, Tracey, and we're going to move down the end. Why do you think women's health has been neglected in healthcare policy, funding and research? Why have we been left out?
I think we were on the too hard pile for a long, long time, weren't we? We didn't use women in clinical trials for medication until, it's only been in about the last 20 years, isn't it, that's actually been allowed because we were too complicated because of our hormones. And so we studied things on men because then they didn't have the fluctuations that we have, but therefore we don't have the results that we can tailor to women. So I think a lot of it is women were seen as complicated, a little bit difficult, and if we go back to our sort of very traditionalist roles, not a priority. And we weren't in the workforce, we didn't have as much of a voice. Yeah. There was all of these things going on, and I think that all those small factors pull them all together and you actually end up gagging us as women. And so it was a completely neglected area. And as a result, we're now reaping the benefits of that in so much as we don't have the information that we really, really need. Yeah. And there's such a lot more to discover. And we are light years behind where we should be. Yeah.
Hazel, what were your thoughts on the subject?
Well, similar to Tracey, I would say that, you know, women have always, they've never been the default, have they? We've always been the other. When it comes to research, clinical trials, diagnostic data, it's always been based on the male body. As Tracey said, women have been considered to be too complex or too hormonal to be included. And as a result, we're finding that, you know, we're getting, you know, areas that are completely under-researched, that we're getting delays in diagnosis, and we've got, like, health systems which are basically based on completely the wrong model as a result. So we're just catching up from decades of systemic exclusion. Yeah.
Joyce, I know this is something that you have spoken about a lot.
I wanted a red light. I didn't have a red light, so I was like, where's my red light?
What could you add to what the ladies have already said?
Yeah, I totally agree with what they say, but it is our time now. Hey, yes. It is our time now. And women's health, menstruation, menopause, fertility, it's really out there and it's really trending. So we are really behind, and there are some basic things that we don't know. So things like medications they were all trialled on men. And we don't respond the same way. So there are things that we really have to catch up on. And I think maybe some of you know things like heart attacks. Women don't have heart attacks in the same way as a man has a heart attack. And that has definitely caused problems in the past.
I only just learned that.
Yeah, there we go. Fact one already this morning. So that's just, there's many other examples. Yeah. The fact that women get more osteoporosis, women get more dementia and Alzheimer's. These are things that we need to research into. And at the moment, we are blaming everything on menopause. But I'm going to shake some of that off in the next presentation that I'm going to do. So we have got catching up to do. And we must really be careful about how we've extrapolated things from a man to a woman. Women are not little men, smaller men. We have very different biology, different genetics. So that's what's been the problem for decades. We've just thought, we can just put everything that we've developed for a man, we'll just move it over to a woman. And we can't do that. Even things like doses of drugs. Yeah. We are smaller than men, but we're not small men. But we have to be really careful. All the drugs, it gives you one dose of everything. Yeah. And we really need to do that more on weight and on gender as well. So, but it is our time. It's happening. It's things like, woohoo, we're here. Do they do an equivalent day like this for men? So lots of men say, well, where's our day? Why have you got a day that's all glitzy and shiny like you've got? But we're here. Anyway, we're not worried about that. So we're here celebrating being women today. So we're
amazing. And what a great day it's going to be. So each of you, you're working with women every day and you're hearing about the frustrations that your patients are experiencing. Tracey, I'll come back to you. What are the main frustrations your patients are expressing to you about the way that things currently are, their access to health, what's going on for them and why they're not getting the help that they feel they need?
I think that the biggest frustration in the NHS world is just being able to access a GP with the right knowledge. Yeah. And that isn't the GP's fault. They are all trying their absolute hardest with minimal resources and minimal time. And you've got to optimise your 10 minutes, haven't you? So I think that's the biggest challenge, and what we need to be doing and what we are doing today is really helping give that support and information so that when you do turn up to your GP, you know how to present it, you know what to say, you know how to make the most of that appointment or even telephone call. But there are lots of barriers, and I think it is just largely down to stretched resources. It's not lack of interest, it's not lack of care, it's lack of resource.
Yeah. Hazel, what's your experience?
Yeah, I mean, as you're saying, access to healthcare is a complete lottery, not just a postcode lottery, but a lottery of who you see on the day. When I did my GP training many years ago, it was mandatory to do a 6-month rotation in obstetrics and gynaecology. And sadly now, the new GPs coming through, that is no longer the case. So some of them have had literally no training in women's health, and not even sort of foundation training. So I think if a woman presents and she's presenting with perimenopausal symptoms, or she's presenting with heavy bleeding, or she's presenting with other women's health problems, she may see a brilliant, well-informed clinician who is really up to date, but equally she may see someone who has had no training in this area and therefore is unable to recognise and unable to manage her problems. And then there's further problems with the huge waiting times for secondary care. So, if you are looking for help on the NHS, you might be waiting 12, 18, 24 months to see a specialist, which if you're barely functioning is just simply not acceptable. And that's why my community gynae service that I work for in the NHS is something that I'm really proud of, because, we are able to reduce the waiting times locally where I work in Warwickshire. And we're seeing women before they reach crisis point and giving them the care that they need. But sadly, these intermediate level services aren't available everywhere.
No, that's so true, isn't it? We've got one amazing GP at my practice, but you can't get in to see her. She's too in demand. So, it's and some people, like you say, don't have anybody that they can access. Joyce, what are your thoughts on this subject?
Yeah, for me, it's education. It's that women have never been taught. Actually, no one's ever been taught, not just the GPs. We haven't been taught how our body works. And my very short story is I started working in a fertility clinic in the 80s, and I had 2 degrees, I had a BSc and a PhD, and I got there and I was like, wow, why am I only now learning about my menstrual cycle and my fertility? What? Really? Anyway, that's why I wrote my book. I started writing it in the 80s. I only finished it a few years ago, but it took a long time. I was doing other things, having kids and blah, blah. But so for me, I'm absolutely passionate that we need to educate women. That's my next talk. It's going to be about educating around menopause. But we need to do this in schools. And I've done surveys of school kids in different countries, including the UK. And do you know what percentage of kids at the moment know anything, are taught anything about endometriosis? Have a guess. Shout a number out. It's slightly better than 0. 2%. 2%, which is probably a teacher with endometriosis that told them.
Yeah.
Anyway, the good news is, I did that work a few years ago now. The good news is, in the UK, our curriculum says we need to teach about reproductive health. We need to talk about difficult menstruation. We need to talk about endometriosis, PCOS. It's actually in our curricula. I think we are the only country in the world that actually even says the words reproductive health and menopause. It's in the curricula. So I'm working with Wellbeing of Women and an international group I run to help teachers roll this out. So we've got a really great project, Wellbeing of Women, about difficult periods. We're working with teachers now. We've developed the resource. We're just fine-tuning it. We're launching it next year. But we want to be sure that everybody, and we want boys and girls educated together in schools. We ask the girls want the boys in the room. There's a few that don't, but I think that's society's stigma that's already there. We need to break that stigma of women's health. We need to normalise conversations about menstruation, menopause, fertility, miscarriage. All of those things need to be out there, and we need to discuss them. We're doing a lot around menopause, but we've got to get in there early and teach everybody this.
Yeah, so true, isn't it? So I remember just hiding tampons up my sleeve, you know, like a... You were so embarrassed, you'd like walk along and you'd like sort of hide it and...
It shouldn't be embarrassing. It should not be embarrassing for a girl to say, I'm on my period. And the men and the boys in our lives have been a bit crap. And I say to everyone, don't blame them. They were probably taught, well, they were definitely taught less than you, and we haven't learnt enough. Most women have told me that it's no more than 2 lessons. Anyone have any more than 2 lessons on periods in school?
No.
I have met a few, my students have just arrived. There were 3 students in a class of about 80 that told me they had 3 lessons. Whoopee! No. My school that in my town, they are now doing a lesson every year. The boys are in the room. They've got brilliant ways of making sure that girls can ask questions totally anonymously that they follow up in the next lesson, and they make the boys hear all of it. Thank goodness. So we just got to do that everywhere.
Amazing. Oh, yes, of course.
Can I ask you a question about that? So that is fantastic. Does it work the other way? I know we're talking about girls today, but is the stuff in there about the boys? Do we talk about erectile dysfunction and all of those kind of things as well?
Yes, we need to. We've done a little bit. We haven't gone as far as erectile dysfunction and ejaculation problems and other. I have done a podcast about those very topics with one of our brilliant urologists, Pippa. But yes, we have got to do more men. I must admit, I'm concentrating on the women. Yeah. I can't do everything, and that's a big enough task. I keep joking that I will retire when everybody in the UK is taught about all this. I might be dead before then.
Oh, funny. Now, one of the things we hear, and I know this from my own experience, is that women often feel like dismissed, or they don't feel like they've been heard. And that was one of the things we put in our Pause manifesto, was the right to be heard. Tracey, how do we change that consultation culture so women feel supported? And I know that's something, obviously, in your private practice, you have that time and you're able to do that. But how can we start, helping people to really feel heard and supported?
So as professionals, I really believe in starting the consultation by giving the patient the floor and then being really, really quiet. And I think it doesn't matter whether that's me in my hour or more consultation, or whether it's somebody in GP practice in their 10-minute section. If you can have a clear 3 minutes even just to speak and be properly listened to, them not tapping on the computer and looking at what's coming up next, but be properly listened to, that is so valuable. And I know in my own clinic I have so many women that will leave after their consultation and they'll say to me, I feel so much better. And I've literally done nothing. They haven't got a prescription in their hand yet. I haven't done anything other than giving them time and space and listen, and they have felt heard. So I think that on its own is tremendously valuable.
It is, isn't it? Because if you feel rushed or you feel like you sort of go in and you think, I've got to get through all these things, to tell my doctor in the 10 minutes that I've got, and you leave and you think, I haven't said everything I wanted to say. So it's really important, isn't it?
I think so. I think we've got a tendency, particularly as clinicians, we want to fix people, don't we? We want to get in there and it's like, before you've started talking, it's like, right, okay, I know what I can do for you. But then that breaks that flow. People feel misunderstood, not heard at all. So we need to learn to shut up a little bit more.
Yeah. Hazel.
No, I agree massively. I think a lot of what I see in my community gynae job is women, when they first come into you, with their barriers right up. And that's because they've just had bad experience after bad experience in the consultations prior to that. Quite simply, we should be believing women. It shouldn't take tears in the consultation room for us to be taking their symptoms seriously. And I think this goes back to medical school and the fact that I think, sort of menopause aware, gender intelligent and trauma-informed communication really needs to be sort of embedded in your medical training, not just an optional extra that you could choose to do should you choose to do that module, but actually part of their core training. Because, sadly, women are not getting what they need from the consultations.
Amazing. Joyce.
We need to listen to each other. We need to listen to other women. We need to find our tribe. We need to find people that are going through similar life stages that we are. We are all different. We are all going to have a different experience of every stage of our lives. So we don't need to try and find someone who's going through exactly the same thing. But I think women's circles, groups of women together that can support each other, I think that's a really, really great way forward. Share your chat and share your issues that you're having with your groups of friends. But remember, they're not going to all have the same experience as you, but let's listen to each other and let's support each other. I think that's a great way to really have camaraderie and really support and make everything better.
Amazing. Now, another one of the barriers that we highlighted was inequality, whether that be in terms of social economic access, whether that be racial, whether that be, I know you've written an article for me before about dyslexia, things like that. So how can we sort of bring more inclusivity into the conversation around women's health as well? Because there are people that are even, as women, we're underrepresented, and then there are communities that are even more underrepresented. How do you address that in your clinic?
So for me, I think a lot of it, so I am lucky. I get lots of very informed and people who can afford to see me, people coming through my door. But that it can't just stop there. You're absolutely right. So the community, there are communities out there and different ethnicities that even don't have words for what menopause is. And it's, for me, I'm in a very privileged position in my private practice, but then that affords me the luxury of being able to go out and do a little bit more in the community. There's an organisation here today called Menopause Hull, which is from where I am from, and actually, not next week, the weekend after, we've got a public-facing event that a lot of people attend, that it's in a shopping centre, so that it's accessible to anybody, and so that people who might not actually feel comfortable or feel heard or feel that they can access their GP, they come to see us in a shopping centre in the centre of Hull for free. So it's about us making, there's a responsibility on us to make these things accessible for women who are struggling or who maybe don't even understand what's going on for them.
Amazing. Hazel.
There's so many barriers, isn't there? Whether it's financial, whether it's educational, whether it's geographical. A lot of women can't afford private care. So that's a financial barrier, geographical. It may be that they can't get to appointments because they've got important childcare, or they've got jobs that they can't leave to go to appointments, or it may be that they simply don't know what support is out there for them. And I think as Tracey was saying, when we do look at providing these services, we need to look at other options. We need to be looking at, can we provide online options? Can we be doing group consultations? Can we translate information into other languages for people? And when we do provide these services, we need to make sure we're not just focusing on the vocal, well-informed women, but the silent ones that aren't currently in this room at the moment.
Yeah, amazing. Joyce?
Yeah, this is a big issue. We've been addressing this a lot. I'm working at a university, so we have the time and energy to make sure that we're working as inclusively as we can and with as diverse population as we can. So with our menopause project, I'm going to tell you about in a minute, we have been doing focus groups with women from very different situations. So we've done focus groups with women, it's all about menopause. So we've asked women who are neurodivergent from different cultures, who are different backgrounds, such as those that had breast cancer, those that have had early menopause, those that have had surgical menopause. We've done the trans and gender diverse community. We've done women who are in same-sex relationships. They all have a different experience, and this is just about menopause. So they've all had a very different experience. They all have different needs. They have different educational needs and different support. So that, for us, is at the top of our agenda. Yeah. But they are all groups that have seriously been neglected. But we've done a survey that's coming out soon, specifically around menopause for Black women. And one of the issues is that they are nervous about talking, even doing an anonymous survey. We really had to push. We did a survey before, an open survey, had like almost 4,000 responses. When we just targeted Black women, we got to about 400. Yeah. We had some great people who are working in this area, menopause while Black, etc. And we really had a problem. We've got to give them the confidence to talk to us and to tell us what their needs are. But there is decades of issues, barriers that we need to break down, for sure. But we want to do some other work. We'd love to do some work with women in the travelling community. I work on Tottenham Court Road. I don't know if anyone's been down Tottenham Court Road recently, but it's full of tents of homeless people, and some of them are women. So some of them women are... Well, all of those women are experiencing the issues I've talked about. We need to do some work with them. There's so many different groups that we need to tap into. Women with different chronic health conditions. Yeah. When am I going to retire?
I don't think you're ever going to retire. Now, we've got a bit of time left, so I want to open it up to some questions. Has anyone in the audience got any questions for our panel?
We know it's a bit early.
Yeah, it's a bit early, but look, you've got these amazing women up here. They can help and support. Then we've got a question over here. This is our lovely Gina from our team, who's running around. God bless her. Looking very sparkly.
Is that working? Okay, yes. Hi, I'm Alessandra. I'm Italian. From my accent, you probably guessed. I like to understand why are we not learning from countries that are doing better than this country? So we all talk about, there is no money here. Well, other countries don't have much more than here, but in Italy, from the moment you actually have your first period, you're followed by a gynecologist, and you go every year, once a year. So the person knows your reproductive health from, the very first period to when you get to the menopause. Why these things are not even considered here? I understand we need to raise awareness between, with children, but there's no point if you have a barrier when you get to the doctor. They tell us, as soon as you've got blood in your urine, go to the doctor. Or if you've got blood in your stool, go to your doctor. You go to the doctor and they give you laxatives, And so why are we being taught the right things, but when it comes to the person that knows the right things, we actually, no learning. So, sorry.
Who wants to take that?
I can start, but then I'll lead it to you. I totally agree. That and that's a problem. We in our work with schools, the well-being of women, and also on their website with their period symptom tracker, they have produced their information about what you should do. And I know there's a session later about how you should talk to your GP, and they have a letter that they want you to give to your GP, etc. But I think that is a major barrier in the UK. And I have lots of friends who are GP, and I'm often giving talks, and there's GPs here, and I hate to criticise, and I've really upset some GPs in the past. And the trouble is, the ones that we're here with here are not the ones that we need to talk to. They're the ones that are not here. So it's not criticism of the people that we're here. But again, since they've never been supported, it is a big hole in our health system in the UK. Solutions?
I think policies need to change enormously, and I think all frontline medical staff, whether it be doctors or nurses or A&E staff, need to have basic women's health and menopause training, and that needs to be mandatory. I also said I think we need to have this funding of intermediate health services to back that up as well. But no, I don't have a magic wand, obviously, to fix it all. No. And I'm aware that GPs are working very hard. I don't do much work in the NHS as a GP anymore. I just tend to do community gynae. But when I did a lot of locum work, and I saw a huge variety in the way women were managed by different doctors. And some of the stories I could tell are just horrific and embarrassing, make me embarrassed to be a GP. But other times, people were managed incredibly well. So, there is just a huge inconsistency there. Yeah.
Tracey, did you have anything to add?
I completely agree. I think our entire health system needs a complete and total overhaul. And the problem is we're working with a system that was set up to fix a problem. I mean, the NHS was meant to last, about 10 years, something like that, get everybody well, and then we won't need it anymore. So the whole focus of the NHS is to fix it when there's a problem system. Yeah. And actually what we need to do is start tackling the downstream problems. And if we could get much more health education out around that, we would release resources in our NHS, because we wouldn't have the amount of other health diseases that we've got to do with lifestyle, highly processed food, all of those kind of things going on. And then we probably would have the resources to concentrate on the actual clinical need that isn't avoidable. But yeah, that's a bit of a utopia situation.
It is, isn't it? But there's so much more, like you were saying earlier, we are starting to get a voice now. Women are, speaking up. And when we come together, we're all very powerful. So I think there's we are starting to change things. That's not going to happen overnight. But hopefully, the more we speak about these things, the more change will come into play. Has anyone else got any other questions? We have got 5 minutes left. So...
Hi, I'm Marizu. I'm actually a midwife. So my question is to Joyce. I see a big gap between saying we have a voice, and RCOG has just launched a manifesto on women's health. However, I don't think it's actually true. I think it's a tick box, because I struggled to have UCL hearing me, to having a research into women's genital health with InMode, because I do offer it privately, and I think NHS should start offering it, but they just didn't want to hear it. They kept saying there is no data, evidence-based gold standard, whereas they have lots of data. So I like to see support from people like you that offer it privately, to work maybe closely in offering what we have in private into NHS, because I've been offering it within the last 12 months and seen a big difference in women's genital health in terms of menopause symptoms, as well as urinary incontinence following childbirth. So really appreciate your input into that as well.
Yeah, so I'm a pure academic, so I don't do anything, I do some talks privately, but I don't do anything else. But listen, even at UCL... I don't get sacked. There's a lack of funding. There's a serious lack of funding. We've let some seriously brilliant people go because they were so I work at the Institute for Women's Health, and we've had some brilliant people who've been working with us, and we had to let them go because there's not been funding. So and there's things we want to do, and there's no funding. We have to go. The project I'm going to tell you about now was initially seeded by UCL, but we have to apply to a big body like the NIHR to get funding. So, but you should have been listened to. I don't know who you saw. Don't tell me now. Tell me later. But yeah.
Is the hypocrisy of RCOG launching that, NHS England talking about wanting to improve
Yes,
it. So
can.
that's where we have to grab the opportunity. I work at UCLA.
Yeah. Talk to me later. Yeah.
Tracy had something to add to that.
Just a little. No, I seem to be plugging the whole area today, but there is an NHS intimate health service using energy-based devices becoming available in Hull, and I think it's the first of its kind in the country.
Amazing.
So you may see. Yes, absolutely. Yes.
And we agree here at Pause. I've actually had the InMode treatment myself for urinary incontinence, and it was amazing. And there's lots of other treatments out there like that. And I mean, I was getting up in the night to go to the toilet, all the things that happen. And it gave me probably about 18 months of complete freedom from that, which was incredible. But unless you've got the sort of money and resources, we've said it should be available to more women through the NHS.
Can I just add, it is a nightmare when you've developed something new and have the evidence to get it in the NHS.
Yes, it takes a long time.
That is a real barrier for us. I've seen it with many, many people. The NHS it's really... So, yeah, we develop new things and then we can't get them out to the women that need them. I totally agree.
Well, look, that was perfect timing. We've just finished. There is Anna Dobby from InMode. We're just talking about your devices. Hello.
Her ears were burnt.
Her ears were burning. So thank you so much. Joyce, thank you for stepping in at the last minute. You were seamlessly integrated into our panel there. Thank you for all listening as well. And I hope you enjoy the rest of today. Stay tuned because Joyce is going to be staying on the stage to talk about being in tune with your body and being prepared for menopause. But ladies, thank you so much. That was great. Thank you.